Welcome back to Crush Medical. We've got another medium difficulty, high yield question for pulmonology. If you find this video helpful, make sure to like and subscribe, and we'll just jump right into it. So we've got a 25-year-old man with asthma who develops abrupt, pleuritic chest pain and dyspnea while walking upstairs. He is tachycardic, hypotensive, and hypoxemic. On exam, breath sounds are markedly reduced on one side, and the chest wall on that side is less mobile than the other. What is the most likely diagnosis? So right off the bat, this is a very tricky question because the clinical presentation can kind of point to a few things. So let's kind of go through this one by one, okay? Let's start with option A, acute severe asthma exacerbation. So we can quickly say that this will be incorrect here. And the reason why is because asthma typically presents with a sense of diffuse wheezing, right? With a prolonged expiration. It's never, not necessarily unilateral in nature, and you wouldn't present unilateral with signs of hypotension, right? So this actually points to something else, which we will quickly get to in a second. But sense of acute asthma, severe exacerbation, this is just not it, okay? Moving on to option B, pleural empyema. This is a really interesting diagnosis. How they like to ask this is basically somebody who develops a they develop a some underlying pneumonia, so it's usually bacterial of nature, and they develop that pneumonia, and along with that develop something called an empyema, which is a collection of fluid that is actually encasing the lung. So this is something that is more toxic and more acute in nature. They're usually present with high fever and signs of bacterial infection that's just not resolving, right? So this empyema, it's a different clinical presentation, right? So in this case, we can say that this would also be incorrect here. A subacute infectious process that begins with fever and pleuritic symptoms, not sudden hemodynamic instability, which is what this patient has, right? Again, going back to this patient, they're just telling us that they have absent breath sounds on one side, it's just not mobile, and now they're also hypotensive, which is really, really important and points to something, okay? Moving forward, let's check out pulmonary embolism. So pulmonary embolism, again, that's where you possibly have a history of a DVT, and the plaque ultimately reaches your lung fields, and now it stops perfusion. And in this case, so that's a different type of clinical presentation, pulmonary embolism, right? So let's just take a quick look. And can cause pleuritic pain and hypoxemia, but it does not produce the unilateral breath sounds that this patient is experiencing, okay? So again, pulmonary embolism, just a different clinical presentation overall, whereas this is more acute in nature. They usually have a history, and there's also some deficits when it comes to perfusion, right? And they wouldn't present with unilateral breath sounds. So we can quickly say that it's probably not a pulmonary embolism, okay? Moving on, we got aspiration pneumonia, option D. So this is a really interesting diagnosis. Also high yield. How examiners like to usually ask this is they will say a patient who is either has a, usually elderlies, whether they're homeless or they have any recent neurological deficits from stroke or motor deficits. What happens is they are unable to swallow their food, and like oral contents, whether that's food and drinks, they just can't push it down. So as a result, you are more likely to aspirate that and develop a secondary infection, right? So a lot of these patients, they typically have dementia, or they have a history of chronic alcohol, where they're actually present with foul breath and a lot more of a bacterial infection type of presentation, right? In this case, that's just not what we see here. We see somebody who has absent breath sounds and the signs of hypotension. So aspiration pneumonia is just not it here, right? Less abrupt, presents with fever, cough, and vocal crackles, not a unilateral respiratory collapse, okay? Ultimately brings us to option E, which is pneumothorax, and that is the correct answer here, right? So sudden pleuritic chest pain and dyspnea with unilateral decreased breath sounds, it strongly suggests pneumothorax, right? The hypotension, so this is really important. Why is it that this patient who developed a spontaneous pneumothorax, most likely, why is it that they develop hypotension? And the reason is because that you have all this air that's being trapped, which ultimately compromises a vascular or venous return, right? So the signs of hypotension is the fact like this patient has a pneumothorax. So until you address the pneumothorax, the vascular symptoms are not going to change, right? So that is something you always have to keep in mind when it comes to management. Because if they were to ask the next best step for this pneumothorax, you actually have to do a procedure, right? And hopefully we'll make a question on that coming up really soon. So be aware for that. At the same time, so this is an acute concern. It's emergent and needs to be addressed right then and there. And quickly, we'll just take a quick read. So unilateral findings of reduced breath sounds, chest wall movement on the affected side. So that's really important. And it's very abrupt in nature. So we'll just walking up the stairs, which is unfortunately how some of these patients can present. We call this a spontaneous pneumothorax. And along with that, the sense of instability, hypotension, tachycardia, and that tells us that there is a tension pneumothorax, which means that there's essentially air being trapped within the pleural space, and as a result, it's compromising vascular and venous return. Okay, so very high yield question, very common, and try not to fall for some of the more the traps that they'll put together, whether that's a empyema or the fact that it could be maybe an asthma exacerbation, which is very common in this age demographics. So beware of the traps, and we look forward to seeing you in the next video.